Hello, and welcome to this Clinical Care Options Medical Specialties podcast. In today's episode, you'll hear from Dr. Michael Blaiss, Clinical Professor of Pediatrics in the Division of Allergy-Immunology at the Medical College of Georgia at Augusta University, as he provides an allergist perspective on refractory chronic cough. Using a clinical case, Dr. Blaiss will cover key points on recognition and management of refractory chronic cough, current understanding of the underlying pathophysiology, and developments in the treatment landscape. This episode is part of a larger educational program titled Reclaiming Control in Refractory Chronic Cough, Evidence-Based Patient-Centered Diagnosis and Care. For more information on Dr. Blaiss, along with a link to the larger educational program, please visit the show notes for this episode. Now let's get started and hear what Dr. Blaiss has to say about this important topic.
Hello, and what I want to do for you today is give you the allergist perspective as we look at patients with chronic cough. And we need to start with that question of why do we cough? Well, it's a very important protective mechanism. It's important as far as being able to clean out the airways from irritants, smoke, mucus. Unfortunately, all of us know as allergists, we see patients on a daily basis that come to us with a cough that in fact has become pathologic. So how do we define cough? And if one goes through the literature, there have been many different ways, but probably the major way is cough duration. So we can divide cough into three groups by duration. One is acute cough, with the most common cause being upper respiratory tract infection. These are by definition a cough that's 3 weeks or less. Next would be a subacute cough from 3 to 8 weeks, with the most common being that post-viral cough, though you can see it with pertussis and mycoplasma. But what we're going to talk about today, in fact, is chronic cough. And these are patients that come to us that have been having cough for greater than 8 weeks. So what is the epidemiology of chronic cough? In fact, it's extremely common. In fact, worldwide numbers suggest somewhere between 10 to 12% of the population. We know that chronic cough can occur at any age, but it's more likely in people over the age of 40. When we look at chronic cough itself, it does have a slight female predominance, and commonly these patients, in fact, have a history of smoking. But a very important subset here is refractory chronic cough. And these are patients that have a chronic cough that we find no diagnosable cause, or the potential underlying causes of the cough had been treated, but unfortunately the cough still persists. So as mentioned, this is a subset of chronic cough. Some studies suggest that up to 40% of patients with chronic cough have refractory chronic cough. We know that it's much more common in women than in men, in fact 3 to 1, and the typical ages that we see are usually patients between the ages of 50 and 70. And it's thought to be driven primarily by a cough reflex hypersensitivity. So what are the symptoms of a cough hypersensitivity? Well, one is that urge to cough. So these patients tell us they get this irritation, this scratchiness, this pain in their throat, or sometimes a tickle in their throat, or they feel that something's there, and they get this urge to cough that they can't stop. They may also have allotussia. And allotussia is a cough triggered by non-tussive stimuli, things like talking, laughing, singing, eating. And these patients commonly have hypertussia, which is an increased sensitivity to a stimulant. Things like cold air, dry air, odor, dust, again, in levels that don't make the normal person have a cough spasm. So how do we evaluate patients that in fact come to us with chronic cough? And there have been many guidelines that have been published over the years, but the one we tend to use the most was developed by cough expert panel from the American College of Chest Physicians. And this was published in their Journal of Chest on classification of cough as a symptom in adults and management algorithms. So they talk about the initial assessment of patients with chronic cough. And obviously, to begin with the history, we need the length of time of the cough, what type of triggers are causing the cough to occur. Is it from different environmental exposures or occupational exposures? What about the family history, especially allergies and asthma? Smoking history is obviously very important. And what type of previous evaluations and treatments have these patients had? We need to know all their medications, prescription, over-the-counter, herbal treatments. And very importantly, are they on any medications that could cause chronic cough, such as ACE inhibitors? So let's look at a patient. Joan is a 51-year-old female with a cough, and she's been having this cough present for about the last 4 years. She tells us that it started with an upper respiratory tract infection. She tells me that her cough is getting worse and she has these uncontrollable bouts. She's been seen by her primary care physician, who's tried different over-the-counter cough medications and even tried benzonatate with a prescription, but that didn't help either. Chest x-ray 2 years ago was in fact completely normal. And she tells me otherwise she's in good health. There's been no weight loss recently with this condition. She tells me the cough is non-productive, and she notices a tickle in her throat before coughing. And she tells me that getting around any mild odor, in fact, causes her to cough. Even laughing causes her to cough. And one of the things that really bothers her is that sometimes when she's having a bad cough spasm, she has bladder leaks associated with it. And therefore, she's very embarrassed to go out in the public because she doesn't know when this would happen again. And the other thing that bothers her, she's afraid she has a serious disease. No one has found, in fact, the cause for her problem. On past medical history, it's really unremarkable. She's had no use of ACE inhibitors. Family history, father with allergic rhinitis. She's a non-smoker, and she's been an accountant for the last 25 years. Her physical exam was unremarkable. Her nose showed some mild swollen turbinates without drainage. Her throat had a slight postnasal drip. Chest was clear. Heart sounds were normal. And her skin, in fact, was clear. Now, if we look at the chest guidelines, it tells us very importantly to look for red flags. And these are conditions that could be associated with life-threatening causes that can lead to chronic cough. Things like hemoptysis, or a smoker older than 45 years of age with a new cough, or a patient with prominent dyspnea, especially at rest or at night, that could be congestive heart failure, or systemic symptoms like fever or weight loss, which could be related to a malignancy, a recurrent pneumonia, or an abnormal respiratory exam and or an abnormal chest x-ray that coincides with the duration of cough. But in this case, in fact, Joan does not show any of these. So where do we go from there in our patient? Well, in most cases of chronic cough, we have a patient like Joan that is immunocompetent, she doesn't smoke, has a normal chest x-ray. There are 4 conditions that we have to evaluate. One is upper airway cough syndrome, which we used to call postnasal drip syndrome, related to sinus and nasal problems, both allergic and or non-allergic, asthma, non-asthmatic eosinophilic bronchitis, and gastroesophageal reflux disease. So first, in Joan, we've assessed her asthma, non-asthmatic eosinophilic bronchitis. Her spirometry was normal with no response to a bronchodilator. We did bronchial provocation testing, and in fact, she showed mild reactivity. Her exhaled nitric oxide was normal at 10 parts per billion. So we did an empiric treatment with oral corticosteroids, a 7-day burst, and in fact, she showed some mild improvement, but unfortunately, her cough has continued to persist. An evaluation of upper airway cough syndrome, I did allergy tests, which were all negative. Her CT of her sinuses was normal. I did an 8-week trial of a first-generation antihistamine, and she showed no improvement. The reason for a first-generation antihistamine is because they have anticholinergic activity, which could help dry up a postnasal drip. And we would not use a second-generation antihistamine here because they do not have anticholinergic activity. And then, as far as GERD, I placed her on PPIs, and we did lifestyle diet change. We had her raise her head of her bed and not eat 3 hours before going to bed. And we did this for 2 months. There was no improvement in her cough. And for that reason, I decided to refer her to a GI specialist for a full reflux workup, which in fact turned out to be negative. So what are we dealing here with Joe? We have a cough that continued despite treatment for underlying asthma, at least from her positive bronchoprovocation test, and we've ruled out all the other causes. So she, by definition, then has refractory chronic cough. So what's next? What do we do today for a patient with refractory chronic cough? Well, one is we can refer to a speech and language pathologist for evaluation, ones that in fact have knowledge as far as treatment of patients with chronic cough. There are many things they can do for them, certain types of exercises, procedures. Very important is laryngeal hygiene. Presently, we have no FDA-approved treatments for patients with refractory chronic cough. Though in the literature, there are some studies showing some neuromodulators may have some benefit for patients, including gabapentin, pregabalin, amitriptyline. Unfortunately, many patients get no benefit, and these come with a great deal of side effects for many patients. Also, opioids are used sometimes, including low-dose morphine. Unfortunately, we know that chronic use of opioids can lead to significant dependency. We could refer to another specialist. If we think there's something else going on in the lungs, we could send that patient to a pulmonologist, maybe to an otolaryngologist for further assessment of the upper airway, and as I did in this patient, refer to GI for a complete reflux workup. And depending upon the area you live in, you may be able to send the patient to a chronic cough center where in fact they would have a multidisciplinary approach as far as management of these patients. Now, what's exciting is that there are a lot of therapies in development for cough that hopefully in the near future we may see for our patients. There are agents that block the P2X3 receptor. There are also agents that block the sodium voltage channel, which is extremely important as it can be triggered and lead to cough. We have a trypsin-8 agonist, which in fact have an effect on a receptor in the upper airway, which seems to be very important as far as stopping cough. And there's also products in development that are kappa opioid receptor agonists, mu opioid receptor antagonists. One, in fact, just finished a phase 2 study that showed significant effect in patients with refractory chronic cough. This is unlike your typical opiates because it does not, in fact, lead to dependency. Very importantly, are the role of P2X3 antagonist in refractory chronic cough. So the P2X receptors are ATP-gated ion channels. And we have the P2X3 and the P2X2/3 receptors that are expressed on vagal sensory neurons, both the peripheral airway terminals and central terminals. Now we know ATP is involved in airway disease and inflammation. It can act as a damage signal, so it's released in response to a lot of different stimuli, injury, inflammation, environmental stimuli, and it itself can drive further inflammation. So ATP, in fact, binds to these P2X receptors and can evoke cough in people with and without chronic cough. But the response, in fact, is greater at lower concentrations in people with chronic cough. So we've had the development, in fact, of P2X3 receptor antagonist. The first product I want to mention is gefapixant. It has finished 2 phase 3 studies and did show a significant decrease in 24-hour cough frequency at both 12 weeks and 24 weeks. Now, this product also has high binding to the P2X2/3 receptor. And this receptor is found on the vagal terminals, but is also found, in fact, in the taste buds, and in fact leads to taste abnormalities associated with the use of this product. In fact, up to 68% of the patients had some type of taste alteration. Now, it did show acceptable safety. Nevertheless, the FDA twice refused to approve this product in the United States, though it is approved in other countries. The next product is camflopixant. And this agent, unlike gefapixant, has minimal activity against the P2X2/3 receptor and therefore has minimal taste alteration. In its phase 2b study, it showed significant effect as far as a decrease in the 24-hour cough frequency. Presently, this product is under phase 3 study, and hopefully in the very near future, we'll have the results with this particular product. So in conclusion, refractory chronic cough is a serious condition that has a major effect on the quality of life of the sufferer. An extensive workup by the allergist is needed in the patient presenting with chronic cough before one labels the patient with refractory chronic cough, as refractory chronic cough basically is a diagnosis now of exclusion. Now, the treatments are limited today for patients we see with refractory chronic cough, but no doubt the future is bright with all the different products in development. Thank you.
Many thanks to Dr. Blaiss and to you, our listeners, for joining us. As a reminder, to view the full program, Reclaiming Control in Refractory Chronic Cough, Evidence-Based, Patient-Centered Diagnosis and Care, please click the link in the show notes. And be sure to check back regularly for more episodes on important medical specialties topics.